Am I clearly audible?
Very much.
Okay. A very good morning to all. I am Arpita from the IGCP group. Welcomes you all to our webinar on the topic Myopathies for Physicians. We are delighted to have you join us for this insightful session focused on the complexities of myopathies, a diverse group of muscle disorder that profoundly impacts patients' quality of life and functional abilities. This webinar is designed to equip physicians with a comprehensive understanding of myopathies, highlighting the latest diagnostic and management approaches that can significantly improve patient outcomes. We are honored to have with us Dr. Satish V. Kadlikar sir, an eminent figure in the field of neurology, as our distinguished speaker for today. Sir is a dean and professor and also the head of the Department of Neurology at the Bombay Hospital Institute of Medical Sciences, Mumbai. With an illustrious career, he has made significant contributions to the field of neurology, particularly in the study of uh, dys- dysphorniopathy and other muscle disorders. Dr. Khadlikar has an impressive academic background, holding degrees such as MD, DM, DNBE, FIAN, FICP, FAMS, and FRCS from London. His research portfolio includes 127 publications that have garnered 803 citations, reflecting his profound impact on the field. Sir's expertise, particularly in the area of muscle disease, makes him the ideal guide for this session. We are confident that his insights will enhance your understanding and management of myopathosis, enabling you to better serve your patients. So, with this very little introduction of Sir, now I would request him to please start with the session. Over to you, Sir.
Thank you. Thank you very much, Ankana. It's a pleasure to be here, associate with the IGCP, and talk about myopathies. The topic I have titled today is Myopathies, What Physicians Should Know. So, we are going to touch upon some of the areas that we see in clinical practice as physicians. Now, in this first slide, look at the classification of myopathies, and this is first of 7 pages. Don't bother to read any. When you open your textbooks, the classifications look very frightening and they go on page after page. But for the practicing physician, myopathies are very simple. You basically divide them into inherited myopathies and acquired myopathy. So when a patient comes to you with what looks like a myopathy, the key question for you as a physician is there a family history and is this a genetic disease? Now, it may sound very simple, but there are times when it is difficult to know when has the disease started, how has it progressed, because myopathies are slow diseases. And when slowly some disability comes, people may not realize or may not notice that the disability is coming. So the onset is often very obscure. And when you go back to questions like, how were you at school in sports? Were you able to climb up the stairs with your bag on your back as a student in school, a student in college? And inquiries like that can tell you how long the disease has been there. So the key question is this an inherited disease? Because myopathies for practicing doctors are divided into inherited and acquired. And on the inherited side, you can see dystrophies, various categories like dystrophies, congenital myopathies, myotonias, mitochondriopathies, periodic paralysis, storage diseases. And on the acquired side, you have endocrine myopathies, inflammatory myopathies, toxic myopathies, drug-induced myopathies, deficiency diseases, and so on. So that's the main question that you're asking. When trying to decide is this a genetic disease or not, please be aware of the fact that when the family size is small, you may or may not get a good history. Please remember that the mother's side of the family is also as much the family. And also remember that some presentations can be pleomorphic. Now, when dealing with a genetic myopathy, what are the key issues? Can the transmission be established? Is it autosomal recessive, autosomal dominant, X linked, mitochondrial, or what have you? Can the culprit gene be detected in India? And the answer to this now is almost to all diseases, yes. What counseling can be offered? How to prevent this disease from getting into the next generation? So, when faced with genetic myopathies, these are the four questions that come to your mind. And as you can see, this requires access to facilities to decide the transmission, to decide the gene, to have expertise on counseling. So, whenever you see a genetic myopathy, it may not be a bad idea to involve a neurologist in the care of the disease so that because they have more access to the facilities, they have seen them again and again, and they have more background knowledge of the situation. But for the physicians, some genetic myopathies should be remembered. One is myotonia, second is periodic paralysis. And myotonia dystrophica, as we know, the common myotonia, is a multi-system disease, comes with diabetes, people have early cataracts, people have infertility, they have balding, and the other myotonias that you see are myotonia congenita and paramyotonia. Paramyotonia is very rare. For a physician, it's important to know that their heart has to be checked, their sugars have to be checked, and they are treated with anti-epileptic drugs and other drugs like mexiletine. Second genetic myopathy to remember is periodic paralysis, where patients get repeated events of limb weakness that recover rapidly. The potassium changes intracellularly and extracellularly at this point in time, and some patients can have cardiac conduction defects. Replacing the potassium and using acetazolamide is the treatment. Now, here is a patient. Here are patients with myotonic dystrophy. You see the swan neck, the low set ears, the fish mouth, sternocleidomastoid is gone. This is myotonia dystrophica. As against that, this is myotonia congenita, where you have large sternomastoid and large muscles. And below is a patient with periodic paralysis with cardiac conduction defects, the Anderson-Tawil syndrome. So remember myotonias, remember periodic paralysis. Now, with that little brief on genetic myopathies, I think let's go to the acquired myopathies, which hold more interest to the physicians. Endocrine myopathies due to thyroid, adrenal, pituitary. Inflammatory myopathies, polymyositis, dermatomyositis, inclusion body myositis. Drug-induced myopathy, there are so many of them, but statins and steroids are the most important. Deficiency diseases like vitamin D deficiency, calcium deficiency. Toxic diseases like rhabdomyolysis, and metabolic diseases where glycogen lipid utilization in the muscle is abnormal, and systemic diseases. So let's recap the categories of acquired myopathies: endocrine, inflammatory, drug induced, deficiency, toxic, and metabolic. So let's take them one by one. Endocrine myopathies are generally chronic and progressive, and they lead to limb girdle syndromes, usually the hip girdle weakness. So people are not able to get up from the ground, not able to get up from the chair, can't easily climb down, have difficulty in taking their shoulders above the head. And in such patients, you find that across a joint, most muscles are weak in a similar manner. Patients don't usually have difficulty in swallowing and chewing, which some other diseases have. The serum CK elevation is usually mild. The exception to this is thyroid, where it can be very high. And when you're suspecting an endocrine myopathy, don't expect changes on electrophysiology. If they are there, they are very mild. In particular, amongst the endocrine myopathies, thyroid myopathies are very important because they present in consulting rooms from time to time. They're common in clinical practice. Thyroid chooses the target end organ, and in some cases, the target end organ can be muscle. Muscles become large and simulate dystrophic process. I once had a child sent to me as Duchenne muscular dystrophy who turned out to have hypothyroidism and recovered with treatment. I also remember a policeman whose calf started becoming larger and he was referred to by a physician. The physician knew that the patient had hypothyroidism, but his note said that this patient of hypothyroidism has probably started developing a muscular dystrophy. Please see. So, in reality, what was happening was that it was a thyroid myopathy looking like a muscular dystrophy. Now, here are some examples from a paper written from NIMHANS by Dr. Nalini and her colleagues, where they analyzed the muscles clinically and some MRI features of the hypothyroidism they gave, and you can see the muscle hypertrophy as shown here. This is one of my patients who I jointly saw with Dr. Girish Soni, where you can see there is a selective hypertrophy of the temporalis muscles. You can see how large the temporalis muscles have become. And the MRI also shows how large they are. And after treating the hypothyroidism, the patient's temporalis muscles and the masseter muscles became better. Now, this is unfortunately, I couldn't upload the videos, but in hypothyroid myopathies, two signs are to be seen. One is the slow relaxing ankle. You tap the tendo Achilles and the ankle contracts and then it relaxes very slowly. And the second is the phenomena of myoedema, where you directly tap a belly of a muscle and a myoedema comes up. Next, from endocrine myopathies, we go to idiopathic inflammatory myopathy. The simple classification is polymyositis, dermatomyositis, inclusion body myositis, myositis with cancer, and myositis with collagen diseases. Clinical features, these are sporadic. They can be subacute, acute, they can also be chronic. They produce some diffuse proximal weakness. Unlike the endocrine myopathies, these patients will have dysphagia and neck weakness. The top slide shows you a neck drop, and they also have skin rashes. Here is the classic heliotrope rash, the lilac colored rash that you see around the orbits. They can also have calcinosis in later stages of the illness. In fact, in some patients, the muscle weakness starts improving and then the calcinosis starts coming. So don't forget inflammatory myopathies. Proximal neck weakness, dysphagia, rashes, limb girdle weakness. CK is markedly elevated in them. The electrophysiology shows a myopathic pattern with spontaneous activity. The biopsies will show inflammatory cells invading the normal muscle fibers, and the MRIs can show inflammation and edema. Here is one such example of a patient who had trapezius muscle involvement, and you can see the signals. The red arrow is showing the signals in the trapezius and also showing in the forearm muscles. The same patient, a trapezius muscle biopsy, shows interstitial inflammatory exudates. And most importantly, here you see a normal fiber being eaten up by the inflammatory cells. So it's the good fibers being eaten up by the bad cells, which is reverse of muscular dystrophy, where bad fibers are being scavenged by the good cells. How do you treat inflammatory myopathies? You treat them with corticosteroids. Corticosteroids you can't use for a long time, so then you give steroid sparing agents, which has traditionally been azathioprine, but methotrexate also can be used, mycophenolate can be used. Cycloserine can be used. In fact, any of them can be used. And if a patient becomes very bad quickly, then you can use a rescue therapy by using IVIG and plasmapheresis. Inclusion body myopathy is a type that doesn't respond too well to therapies in general. From inflammatory myopathies, which is a very important category, we go to toxic myopathy. These can be necrotizing, antimicrotubular, or hypokalemic. The necrotizing ones are seen in statins, tacrolimus, cyclosporin, and some beta blockers like labetalol and propranolol. Antimicrotubular cancer drugs, the vincristine, vinblastine, and that group. Hypokalemic due to in diuretic, laxative, amphotericin, and sometimes in steroids. So these are the three categories of toxic myopathy. Let's touch upon statin-induced myopathy. Statins commonly cause muscle aches and pains without anything more in almost 1 to 2 out of 10 patients. They produce elevation of CPK in zero point 0.1 to 0.5%, which is dose dependent. Also, the duration of statin therapy, 6 months before the onset of symptoms, and after stopping statin, they go on for 2 months. So they're dose related, they're duration related, and they're generally myalgias, but can sometimes be elevation of CPK and frank weakness as well. Now, who's at risk of statin induced myopathy? Older individuals, ladies, low BMI, systemic diseases like tuberculosis, liver disease, kidney disease, vigorous exercises along with statins, excess of alcohol, intercurrent infections, trauma, surgery, stress, and sometimes genetic factors. Now, drug interactions with CYP3A4 agents, there are so many of them, and statins misreact with these drugs. How do you manage statin myopathy? If patient has significant muscle symptoms, discontinue statin. If the patient is asymptomatic but with CK elevation less than 10 times the upper limit of normal, then again discontinue statin. Rhabdomyolysis, no statins at any time due to risk of recurrence. If a patient requires a statin but muscle toxicity other than rhabdomyolysis, discontinue statin. Once symptoms are resolved and CK has returned to baseline, you can try another statin like pravastatin or fluvastatin. Then there is a myopathy which persists or progresses after stopping the statin. It's not dose related, it's not duration related. Statin sets off an immunological response. This is called statin associated necrotizing myopathy, and it links to autoantibodies against the HMG CoA reductase. And now in India, you can check the levels of HMG CoA reductase. They have distinct muscle biopsy findings in that macrophages infiltrate engulfing necrotic muscle fibers, and in some people, they have only necrotic muscle fibers, and these respond to immunotherapy. So these are to be treated like inflammatory myopathies. This is an example of a patient showing interstitial inflammatory exudate in a patient with statin associated myopathy. Then we must discuss a little about steroid myopathy. Steroids are used very commonly, and chronic corticosteroid use gives rise to a myopathy in a group of people. Usually affects the lower limbs, CPK is not elevated, and if you do a muscle biopsy and stain it with ATPase, the type 2B fibers atrophy, but this requires the special staining. Then we must know a little about vitamin D deficiency myopathy, which is still seen in India from time to time. And people who use burqa, who had multiple pregnancies, dietary deficiencies, they are all harbingers of this condition. It presents with lower limb weakness. It is a painful weakness, unlike most other muscle diseases that we saw up till now. pains dominate. Reflexes are brisk, CK is normal, and electrophysiology, as I told you earlier on, can be normal in metabolic myopathy. They respond very well to the replacement therapy. A physician is likely to come across rhabdomyolysis from time to time, which produces sudden severe muscle weakness and muscle pains. And a whole lot of things can cause rhabdomyolysis. The leading cause is drugs, statin, clofibrate, colchicine, abuse potential drugs, cocaine, heroin, alcohol, viral infections, serotonin syndrome, snake venom, tetanus, and mushroom toxicity. There's an extreme CK elevation from many thousands to a lakh or more than a lakh. Myoglobin enters the urine, myoglobin enters the kidneys, and there is a renal dysfunction. This requires monitoring of the renal function, hydration, alkalinizing the urine, and in a patient of snake venom toxicity, antivenom in immunoglobulins. From toxic, we go to metabolic myopathies, where the groups are glycogen storage disease, lipid storage disease, and mitochondriopathy. And what are the clinical features? Chronic myopathy, with or without exercise intolerance. These diseases, like muscular dystrophies, do produce chronic progressive muscular weakness, but exercise intolerance is seen in a proportion of patients. In people who have a lipid storage disease, there is a second wind phenomenon. And mitochondriopathy is a pleomorphic involvement of the central and the peripheral nervous system. So, those are the broad clinical features. How do you diagnose them? Muscle biopsy is very useful. And you can see the right side panel is a glycogen storage disease with the HNE showing the red arrow is pointing to fibers that are laden with glycogen. And when you use a PAS stain, as you see in the left bottom half, the PAS stain stains the glycogen. The right top shows the ragged red fiber, which is characteristic of a mitochondrial myopathy, and the bottom shows the coarse lipid granules that you see in a lipid storage myopathy on a ORO stain. So to diagnose them on a muscle biopsy, you need not only HNE, you need some basic special stains. Admission to ICU. So basically, what's the setting? Has had sepsis or has received a lot of steroids. This is the setting in which critical illness myopathy. Steroid use, neuromuscular agents, severity of the illness.
Sorry everyone for the interruption. I think there is some issue with the network connectivity of Dr. Haldikar sir. So I would request everyone to please stay with us. Sir will be joining shortly. So I think there was some network issue. So you can upload the slides again and continue from there. Yes, sir. It has been uploaded.
I'm actually finishing now.
Okay, okay, sir.
Yeah, just one or two slides remaining. Anyway, so I think we almost come to the end of the presentation. And to recap, I think we can say that genetic myopathies and acquired myopathies, the basic classification. Genetic myopathies you can leave to the neurologist. The acquired myopathies you must know. In acquired myopathy, you must know the endocrine myopathies, the toxic myopathies, the drug-induced myopathies, and these are partly reversible. Yeah, actually done. We can points. Ankana, we can take questions. Hello.
Yes, am I audible?
Hello, Ankana, can you hear me?
Yes, I can hear you. Can you hear me, sir? Hello? Sir, am I audible?
Hello.
Hello, sir, am I audible? Hello, sir, am I audible now? Sir, am I audible to you? Hello, sir, am I audible to you, sir? Hello, sir, am I audible to you, sir? Hello, sir, am I audible to you, sir? Hello? Hello, sir, am I audible to you, sir? I would request all audiences who have joined to please be patient. Sir is having some network issues, so once Sir joins, we'll continue with the session.
Yeah.
Sir, am I audible now?
Yes.
Okay, okay, sir. So we'll take two, three questions and we'll wrap up the
Yes.
session.
Yes.
So audiences, I would request everyone if you have any questions, please put them up. Sir, one question has come, that is, what role does physical therapy play in long-term management of myopathies, and how can it be tailored to improve patient outcomes?
See, in conditions where you do not have a cure, the genetic myopathies, you have to rely on physical therapy. So, physical therapy and occupational therapy, in fact, becomes the mainstay of treatment for these conditions. It's of two types, stretching and strengthening, because some diseases produce contracture. So, you want to stretch the muscles in a way that the joints remain mobile. And then you give strengthening exercises so that whichever part of the muscle is not that much affected by the disease gets strength. So, yes, physical therapy is extremely important. Along with that, occupational therapy. If somebody has a foot drop, then a foot drop splint will go a long way in improving his walk. And the same for the knee buckling patients, the knee brace. So, PT and OT, physiotherapy and occupational therapy, very important parts. Yes.
Right, sir. There's another question, that is, how do you approach the patient of myopathy who experience significant side effect from corticosteroids or other immunosuppressive therapies?
It's a very broad question. I don't know what the
Um,
person exactly wants to know.
okay.
Normally, we start with steroids. If steroids are tolerated, then that is good. But if they're not tolerated, then you gradually reduce the dose and you shift to a second immunosuppressant. The choice of the second immunosuppressant depends upon the patient profile, age of the patient, the comorbidities, sex of the patient. That tells you which one will you use, and it also depends on how comfortable or familiar you are as a doctor with a drug, second immunosuppressant that you want to use. So currently the choices are between azathioprine, methotrexate, mycophenolate, as first line, if you like. And if they don't work, then you go to other agents like tacrolimus, cyclosporine, and drugs like that. Yeah. If a patient develops side effect due to the one that you have chosen, you will have to move to another one. So it's a patient based tailored treatment for every patient.
Right, sir. So another question has come. So, differential diagnosis for inflammatory myopathies from other muscle disorder.
It's the diagnosis is made by clinical features. If it's an acute subacute myopathy, if it involves the neck muscle and swallowing, then you are more inclined to inflammatory myopathy. CPK is usually grossly elevated. And then the key comes to muscle biopsy, where you show inflammatory cells affecting the normal muscle fibers. In some patients, there may be skin involvement, and the skin rashes like the Grotron papules or mechanics hands, they might give you a clue. So these are the diagnostic clues. The differential diagnosis in India is a sporadic limb-girdle muscular dystrophy, which looks quite similar to inflammatory myopathy, but it develops slowly and it hardly ever produces dysphagia. So those are the two differentiating points.
Right, sir. Sir, one last question. In
Yes.
cases of congenital myopathies, what are the latest genetic testing advancement and how do they influence the treatment strategies?
Congenital myopathies has become a huge topic by itself now, and there are literally so many types known. There are issues about genotype phenotype correlation, but it's a group that is expanding. For all genetic myopathies, treatments are still experimental. Only diseases like Pompe disease or lipid storage disease or glutaric aciduria, you have some treatments. But for most, it's still in research stage. Yeah,
Right, sir. Sir, there are no more queries for today. So,
right.
with that note, we would like to end the session here. But thank you, sir. Thank you so much for giving us your valuable time and sharing all your knowledge with the audiences. Thank you, sir, and thank you all
Thank,
for joining in. Thank you, sir.
thank,
Have a good day
thank
ahead.
you very much. I enjoyed
Thank you.
it. And if there are questions that come later on, also do send them to me. I'll answer.
Sure, sure, sir. Sure, sir.
Okay.
Thank you so
Bye.
much, sir. Thank you.
Bye now. Thank you.
Bye, sir.